next presenter is Dr. Dana Telem from Stony Brook, and he has done a very intriguing survey on the emergency department visits after cholecystectomy, the New York State experience.
Oh, thank you. Great, thanks. Thank you so much. I concur with Ben's sentiments about being completely humbled and grateful to be up here and to have been made a part of this task force, and I couldn't be happier to be here. And what we're going to present today, oh, there we go. We're talking about health resource utilization, which is becoming an ever-present and increasingly important topic, particularly in this new healthcare paradigm of value-based medicine. So I have a couple disclosures, none which are relevant to this topic, but I will disclose that Sage has gifted me this onesie for my baby, and I am influenced by Sage's, so much so that I have even implemented the critical view timeout in my practice based on this task force. So a little bit like what Dr. Brunt said earlier, cholecystectomy is one of the most frequent operations that we perform, with over 750,000 a year. It's performed countrywide and nationwide by all general surgeons. We don't need special training or certification, and we really start as low-level residents. Think about your practice, think about who's coming to your cholecystectomies, and think about what cases you're letting your chief resident or fellow take your interns and second years through. We kind of start thinking about this operation sort of a slam dunk. We expect our patient to come in, we expect them to do well, and we expect them to go home that day. But what's the data on this? In 2010, a statistical brief from the Healthcare Cost and Utilization Project demonstrated a 9.5% readmission rate after this procedure. But really, readmissions may not be the sole reflector of healthcare burden. We have limited data on ED utilization. And ED utilization is a significant healthcare burden, which is essentially responsible for our $38 billion annual expenditure. This expenditure is really comprised of two factors. One is the quantity of preventative visits, namely visits that could be treated in an outpatient setting, and two are frequency. We all know the frequent flyers, and there's data to support that it's really the 5% that incur the majority of the cost. So you're probably sitting in the audience and thinking, why am I here, and why does this have anything to do with my outpatient lap chole that I'm going to go back and do on Monday? So we looked at this data for New York, and this was a question I was interested in, and we identified through a longitudinal administrative database all patients undergoing lap chole for cholelithiasis or cholecystitis, no special disease processes. This database is interesting because it is not a sample. It actually reflects every inpatient, outpatient, and cholecystectomy that occurs in the state of New York, and you can have longitudinal data and you can follow patients out with a unique identifier, meaning you can pick them up no matter what hospital they go to as long as it's in New York State. We followed these patients for 30 days from 2008 to 2010 and looked at about 97,000 patients, looking at ED visitation and readmission rate and really what the risk factors for these were. So what did we find? The 30-day ED utilization rate was 9.5%, but more interestingly, about 60% of patients were being discharged from the ER, which really calls their visit into question in the first place. When we looked at frequency of ED utilization, again, the majority of patients had one visit. However, there were a subset of patients, 1.5% with more than 2 visits, and the range of visitation was 1 to 18. There were a few patients that had 18 visits within 30 days of lap chole. So what does this mean if we talk dollars and cents? So if you assume about 750,000 lap choles performed annually with a 9.5% ED visitation rate, you're talking about 71,000 ED visits a year. If the average cost of an ED visit is about $1,300, as was surveyed in the medical expenditure panel, you're talking about an expense of $94 million from your outpatient chole coming to the emergency department. Now, if you want to take it one step further, and you think of this as a 60% discharge rate, meaning did they really need to be there in the first place, we're talking $56 million from your outpatient procedure. And I think that this is a clear deliverable and something we can all work on to reduce healthcare costs. So who's coming? This is a little bit busy of a slide, but I'll break this down. Younger age, male, Black, self-pay and CMS insured, and a myriad of comorbid conditions that include rheumatoid arthritis, CHF, pulmonary disease, depression, diabetes, drug abuse, hypertension, liver disease, PVD, psychosis, and renal failure. Really no surprise. What was really interesting is when we looked at complications, we really didn't see that having a complication increased your likelihood of coming to the ER unless that complication was phlebitis. We also did a geographic mapping of the utilization in New York. This is me, unfortunately, and as you can see, we are not on the good end of that scale. But you can see that there's a lot of geographic variance in terms of where the ED is being utilized. Now, more importantly, is we wanted to look at who is being admitted and who is being discharged home. And interestingly, we saw two separate camps. The discharged patients tended to be younger, Black or Hispanic, and Medicaid insured. The patients admitted were more typically Medicare patients, patients with CHF, diabetes, and renal failure. And I don't think this is really a surprise. But the main question is why? Now, one of the limitations of an administrative database is you really can't deep dive into the clinical information and figure out what were all the factors that brought people there. But I can tell you from assessing the ICD-9 codes that abdominal pain, dehydration, nausea, vomiting, infections, both wound and urine were the predominant reasons people came. Ultimately, however, this is really the next opportunity for healthcare delivery improvement. So what can we do? I think it's important to manage the expectations of patients. I think, as Dr. Schweitzberg said earlier, having a patient who understands not just the good that can happen, but what the potential downfalls and what their specific risk for them is very important. Ensure appropriate analgesia. I can't tell you the number of times a prescription didn't go through, my office got called, it's after 6, no one picks up, where are they gonna come for their pain medication? The emergency department. Closer monitoring of identified high-risk patients, and really I think it's important to have patient action plans for weekends and after-hours care so that your resident's not picking up the phone and saying, oh, just come to the ER, whoever your answering service is directing that. So even though lap chole is not always a slam dunk that you think that it's gonna be, I think that we can work together to really reduce this healthcare burden. Thank you.